Good afternoon, everyone. Fire has been interested in health for quite a long time, and I want to introduce an aspect that I speak mostly when I'm speaking nationally, especially. You know, we don't have a mission or a vision or any of that within the organisation. We think that the business speak has lost a lot of middle managers and certainly the operational staff in the past. But we do have a purpose, and it's very closely aligned to that purpose of Public Health England, which is to protect and improve the quality of life of the people in Greater Manchester. And there's a couple of comments there that kind of feed into the reasons why we are involved in some of the work that we're involved in now, especially with ambulance service colleagues, health colleagues, police colleagues. You know, some of those comments, you know, resonate widely throughout our own workforce. You know, there's about 200 people a year lose their lives in fires, whereby Andy Newton thinks that if we responded to cardiac arrests in addition to fires, we would also save an additional 1,000 people, which is quite a lot when you think of it, considering the impact that cardiac arrests have on communities right across England. You know, the statistic in Manchester is quite stark. If ambulance service are responding to you as a result of a cardiac arrest, your likelihood of survival is somewhere in the region of 1 in 20 or 5%. And Simon Stevens has let us all know that there's 250,000 people a year that are crossing the threshold of accident and emergency units as a result of falls. All these areas we believe that we can have an impact on to help health colleagues, and especially to take prevention into certainly a new era from a fire and rescue service point of view. You know, people believe that we've changed only recently. It started 20 years ago with a number of reports, and I'm sure you'll have time at some stage in your leisure to read through some of these, but the one that's driving us at the minute is certainly the 5-year forward view and a public statement that Simon Stevens has made with regards to the health service can learn from the journey that the fire and rescue service has been on. Just to give you a slide that kind of indicates where we have been. In 2005, 2006, we started to do home safety checks in people's homes. Those that we felt, anybody's home in fact, anybody that asked us, we would go in and do a home safety check, and where necessary, we would fit a smoke detector. But you can see the performance in 2005, 2006. In Greater Manchester, we were only in about 600 homes. At the height of activity in people's homes, we were in almost 100,000, and that was 2009, 2010. But a lot of that was on the basis of partnerships. A lot of those partnerships have since disappeared because of austerity. But you can see that even last year we were still in 55,000 homes across Greater Manchester. This year's target, which came to an end on the 31st of March, is in excess of 60,000, so that just hasn't been updated yet. But it shows that even though partners aren't getting involved, we still have a lot of activity. Now, that's not just into any person's home now. We've been using risk stratification for a number of years now in the Fire and Rescue Service, and we've got an agreement with the Public of Greater Manchester that we target those that are most at risk from fire. The irony is that those that are most at risk from fire are most at risk from all of the other ailments that we know impact so heavily on the health and social care systems. You know, we can see that our performance since 2005, the blue line shows our increased prevention activity, and the red line shows our decrease in accidental dwelling fires, which are those fires that mostly cause fire deaths. You can see that we've reduced the impact by well over 1,700 in Greater Manchester, whilst we still show that we've got a high level of activity in people's homes. That was the impact of home safety checks, but you can also see the response activity and how it has peaked and now troughed. So at the height of performance, you know, we were attending, and these are only a range of the incidents, these aren't all of the incidents that we attend in Greater Manchester, but in 2003, 2004, we were attending almost 60,000 incidents, and by last year's stats, we had that down by 2/3. So we've taken about 66% of the demand out of the system by addressing the risk. You know, everybody knows that Manchester's in a new position, and certainly with a new devolved administration and a new mayor in the offing in 2017, there's an additional offer that fire can bring, certainly within a metropolitan fire and rescue service. You know, we've got access to 60,000 homes. You can hear by my enthusiasm for this that we certainly have strategic commitment. We already have significant referral pathways into and out of other organisations. There is a bit of information sharing, and Beverly, it was really good to hear that you believe that there has to be some kind of formal arrangement between the NHS and ourselves regarding sharing data, because that has been one of our biggest challenges, is getting through the health system. And we've got some anecdotes which are really, really poor, which show the emphasis that needs placed in this. All of our fire stations, the public have already paid for, so we believe that our health partners and social care partners should be using those fire stations as assets of their own, you know, to engage with older people, to engage with younger people. We've got community rooms in all of our stations, and the partnerships we've already struck up are with people such as the Driving and Standards Agency, who use our fire stations for driving test centres. But we've also got other partners that are embedded within our fire stations now, and one of our fire stations even has a climbing wall to try and increase the activity of young people in that area, which is an area of high social deprivation. And the bit in red, and the bubble in red, is the area that most people will want me to talk about, and that is the new concept that we've developed over the last 6 months, which is community risk intervention teams. Moving on, just to talk about the response element, you can see the difference that our prevention activity has had, even in the last number of years. And if you take two corresponding quarters, with fire on the left and ambulance on the right, you can see at two different quarters in 2 different years that the demand for fire has reduced again dramatically, whilst at the same time demand for the ambulance service has increased dramatically. And the irony there is that we're dealing with the same demographics. So we know that the people who are most likely to die from fire are older people, are those middle-aged men living on their own in private rented accommodation, usually with some substance use issue. And we've got a lot of data and information that sits behind that. Accidental deaths in the home, I referred you to a comment made by Simon Stevens. Even though we're losing about 200, 210 people a year from fires across England, that equates to about 8% of people that die from accidents in the home. Falls represents 43%, and I know most of you all know this, but we believe in the Fire and Rescue Service we can help prevent all of those accidental deaths in the home because we are in so many homes every year. A wee bit about Seattle Life Support Service, and this is to do with cardiac arrest. I spent some time there recently just looking at their model. I told you that in Manchester you've probably got somewhere in the region of a 1 in 20 chance of survival. Well, in Seattle it's 65%. Now, the comical suggestion that I make usually is that we can all move to Seattle, or we can start to adopt their model, certainly in Greater Manchester, and we think we're on the verge of doing that with all of our firefighters. You know, some of the stats in there are quite stark. You know, anywhere above 60% is probably the world best. But in Seattle, you're 4 to 5 times more likely to survive a cardiac arrest than you are anywhere else in America. Yeah. So there is quite good information and quite good experience over there that we can learn from as a fire and rescue service. You know, for us, we feel that we are already, but we can do more in supporting health and social care across Greater Manchester. In Wigan already, which is one of our 10 boroughs, all of our firefighters are trained as public health champions. In Bolton, firefighters are preventing sudden infant death syndrome by the engagement with communities and young mothers, and by providing equipment which help young mothers be more cautious around how they're bringing up their young children. In Salford and Bury, firefighters have been completing falls risk assessments and referring to falls teams now for about 3.5 years. And we have now introduced this new concept, which is community risk intervention teams, which are now working across all of Greater Manchester. You know, it's just a visual of what these teams look like. They don't respond under blue light, but they have basic life support equipment that they carry, and they're involved in a number of very, very important activities. It's based on it's a multi-agency, multidisciplinary prevention and response team, and the targeted work is based on an agreed risk profile. So we're linked in with our colleagues in health and social care with the local integrated teams which are being established across Greater Manchester. So we don't sit outside that, we sit within it. And all of our objectives are set by the health service and the local authorities, social care, Greater Manchester Police, North West Ambulance Service, and of course ourselves. And what activities they actually take part in, they carry out falls risk assessments, but they also fit falls equipment, and I'll maybe talk about some of the impact that's been having now since they started operating. They also carry out cardiac rescue, so they respond to cardiac arrests on behalf of North West Ambulance Service, and they have been very successful in saving people's lives in doing that, even though they don't respond under blue light at present. They do crime prevention activities on behalf of police. We know how crime prevention has been cut back within Greater Manchester Police and other police services, so we're able to fill a gap there when we're in the homes of the most vulnerable and increase the confidence against crime within people's homes. We do, of course, as you would imagine, fire and CO prevention, carbon monoxide prevention, but when we're there, we're also offering health and wellbeing advice to the occupants, as well as engaging in the young people and diverting some of those young people into our schemes as well. We were very selfish in recruitment for these special teams, and we went for returning military personnel who had the prerequisite skills, but we also had volunteers from the ambulance service, the police service, and ourselves, and we found that a very successful model to recruit from. The vehicle design includes capacity for specialist lifting equipment, and that's for lifting those that have fallen in the home, and specialist equipment again for lifting bariatric patients. They have the facility to convey patients, but only to the likes of GP surgeries and urgent care facilities. We don't convey patients to hospital A&E. They're available for community resilience, so the doctors or care workers can use these vehicles in adverse weather conditions if they want to respond to somebody who's isolated in their home. And the pilot that has been running for the last 6 months has been running across 3 of our biggest metropolitan borough council areas, Wigan, Salford and Manchester. And as everybody would want to know is what impact is this type of a pilot having, and we're using our new economy, which provides a cost-benefit analysis model, but also that robust academic rigour has been provided by Salford University. Of course, there's been challenges, and I've had personal challenges to me. The Fire Brigade Union, when they first heard of this, seen it as me trying to set up a new 4th service, but also that we were trying to cut back on fire and rescue jobs and firefighters' jobs. The opposite was actually true, and we've now, certainly we believe, expanded the minds of firefighters to view the activities that they take part in somebody's homes and how they can impact more widely, not only reducing the risk of fire, but reducing of all the other risks that we've alluded to. Just to give you a bit of an indication of considering that these are only 3 teams in a metropolitan area, which is quite extensive. If you look at the bottom line here, you can see that already, with regards to response, they have responded over 1,500 times to people's homes where people have fallen, where somebody's had a cardiac arrest, or where the police ordinarily would have been called to a call for welfare concern. There's a stat just out today that highlights that only 22% of calls that police actually attend are crime related. Most of the impact on their demand are through calls for welfare, and we can see how that we can help that going forward. But you can see, even though the 3 teams were based in 3 of our boroughs, they've actually extended what they provide right across Greater Manchester. It'll be no surprise now that the Health Service in Manchester, social care systems and the chief executives of all of the Metropolitan Borough Councils want their own facility locally. And we'll be able to give that to them very, very soon by using all of our fire engines and all of our firefighters. So those 3 teams will become 66 teams not long now into the rest of this year. And you can imagine the impact that can have on demand, not only for health and social care, but also our colleagues in the police. We constantly get challenged about the role of a firefighter, and would you rather have a firefighter as opposed to a social worker or an occupational therapist? In no way are we suggesting that firefighters will become paramedics. I don't want to run an ambulance service. I certainly don't want to run a police service. And for me, what we're offering here is complementary to what those services can currently provide. We understand the challenges that everybody is under, but the service we provide is one that's additional to, complementary to, and what we can find is that we can respond and be there slightly quicker than other agencies, and therefore we can have an impact on survivability. The other bit is, will it impact on the demand that we have as a fire and rescue service? Will we be able to still respond? Well, we've been using risk stratification. We've also been using how we start to run our services down after we've had an impact on calls. We've dealt with many major emergencies across the years that I've been in Manchester, and never have we been stretched to the point where we won't have enough resource to be able to help out where all our partners needed. So I think that we've started to alleviate all those concerns of the representative bodies and from our partners across Greater Manchester as well. So going forward now, fire as a health asset is starting to land in the minds of quite a few people. I spent an hour on Tuesday with Duncan Selby from Public Health England, and Duncan is highly impressed by what fire can offer, certainly in Greater Manchester, but as we start to roll things out across the country, we could have a major impact on future demand, especially in the run-up to winter. Greater Manchester firefighters are asking now to be medical first responders and respond to cardiac arrests. They also want to start delivering basic health and well-being awareness and training in schools, including CPR. So there's a lot of engagement. We're in every primary school in Greater Manchester. That's over 800 primary schools. So we've given an undertaking to every child that we'll be with them at least at one time in the later part of their primary school career, to be able to engage with them about fire safety, now about health and well-being awareness, but also to give them other practical skills. Firefighters and community risk reduction teams will complete health, falls, crime and fire risk assessments in the home, and within the Chief Fire Officers Association, we've rebranded the old home fire safety check, and we're calling it a safe and well visit, and it's much more comprehensive now with linkages in the other partners. I've put certainly a bullet point at the bottom of the screen, more for to challenge sensitivities across the piece. You know, I've got trauma technicians who are trained in a higher level of medical and pre-hospital patient care. That the governance arrangement for that sits under North West Ambulance Service. So we have a consultant who is our clinical governor who looks after everything that we do. If I get into 60,000 homes of those that are most exposed to the winter conditions issue, who are isolated in their own home, who are invariably impacted on the capacity of local GPs to be able to provide a service to everyone, why wouldn't those trauma technicians start issuing inoculations, flu inoculations to those most vulnerable of actually having flu as a serious and critical impactor on their health and well-being? You know, that's 60,000 opportunities in 60,000 homes, but multiply that up with the number of older people that live in those homes. You know, the future, and this may be me putting my neck on the block here, but is the future for Greater Manchester one emergency service? It may well be. It may well be that we, you know, that we have one governance structure through the new mayoral model. I want to finish with an anecdote to let you know how the system is currently impacting, and that anecdote is relating to a bariatric patient who had a severely advanced cancer, which was invariably going to shorten his life within the period that we knew him. He fell in his home on a Thursday evening, and our community risk intervention team responded. The man was on crutches, but the crutches were no good anymore to sustain his movement around the home. He didn't really want social care involvement, but he wanted to stay with his family, and he wanted his family to be around him. Now, the community risk intervention team, there was cause for concern regarding some of his vital signs, and they asked for the ambulance to attend. The ambulance attended, and as you can imagine, he went to A&E, he was trialised, and he was put into a secondary care bed. Now, most of you guys will know that because of the stage he was at in his life and the illness that he had, the likelihood of him getting back out of hospital again was remote. And if he did get out of hospital, he probably was likely to go to another part of the health system to look after him until his life ended. Now, once social care get involved in that, it's a case of the assessment in the hospital, the relationship with the consultant. Once the consultant asks for the person to be moved, the responsibility goes on to social care. Social care then have to see if they can re-able the home to get that gentleman back out again. And of course, all of that impacts on the flow through from A&E into secondary care, bed availability, and of course social services having to go to that person's home to re-able it, the cost, the time, the involvement, and we all know the length of time period that can sometimes take, especially around budgets and availability of equipment. The gentleman went into hospital on the Thursday evening and he was back in his own home on the Sunday morning because those fire and rescue service employees not only did the risk assessment, they fitted the falls equipment as well to allow that gentleman to move around the home. The important thing here, and you'll hear this more regularly now, we're treating, you know, it's not what the matter was, what was the matter with that gentleman, it was what mattered to him. He wanted to be back in his home and we made that possible. As a result of that, and this is where the cost savings start to come into it, which is slightly more inhumane, is that Manchester City Council, who had had trouble trying to get information from of those most vulnerable in the home, the next day they were due to go out to a procurement exercise to have falls equipment fitted in 512 addresses across Greater Manchester. They had the equipment already purchased, but they were going to pay a private sector organisation to go and fit that for them. I told them we would do that free of charge. We have now went through all of those address lists and fitted that equipment free of charge. Why would I do that? Well, it gives me access to those that are most vulnerable in those homes for a variety of reasons, including that selfish interest which I have as fire risk. But the saving to Greater Manchester, or to Manchester City Council in the first instance, was significant. And you can imagine that every chief executive now across Greater Manchester wants the same service in addition to that. That's a fly-through, folks, and I'm willing to hand back now for questions that people might have.